Well, hello, everybody. As you see, we are going to have what we hope feels like a more informal session where you can imagine us as sitting around the dining room table in your house and having a conversation. And that's why we won't be speaking at a podium. We're going to be speaking in these easy chairs. And we hope to have a conversation with each other, but we also want to have a conversation with you. So please, during the brief presentations we'll each be making, think about how what we're talking about relates to your work, and please be ready to ask a question or share an experience so that we can truly have a discussion. This is a session about crossing boundaries and building bridges across sectors. And you will be hearing from the three leaders to my right about their own experiences in terms of crossing the professional boundaries and the successes they've had in developing new and trusting and meaningful partnerships that have made real differences in terms of the communities that they've been involved in. And their experiences are in diverse settings, sometimes by geography, by demographics, by density of population, and also the sectors themselves are diverse. Some involve health and public health, but they involve other non-health oriented sectors. I would share with you my own experience for a minute or two in terms of this type of work. I now work at Trust for America's Health, but I've had different jobs, starting out as a community and labor organizer and then working at the local, state, and federal level in public health. And I've often had experiences in those different settings of the importance of building these intersector relationships and overcoming the boundaries. I would say I probably made every mistake you can make. That's how you learn from attempting to do the work. If I was thinking about a couple of lessons I'd share with you, I'd share two very briefly. Sometimes these lessons just seem like matter of fact and common sense, but I would just share them with you to begin with. One is I learned how important it is in building these partnerships to make sure that the interests of each of the parties involved is taken into account, respected, and whenever possible addressed, so that the collaborative work is based on the interests of the participants and not simply the goal of an individual group, say the health sector or the public health sector, trying to convince everyone else that they should be working on a health-related issue. A second lesson I think I've learned is the importance, whenever possible, of respecting the cultural, language, and past experiences of the partner, and that without that, true trust can't be built. And I think we'll hear examples of that from our speakers. But I saw some examples of this when I was a state health official, when we were building connections with the transportation department within the state. We had a wonderful person from the health department who literally spent 18 months going to meetings with the transportation department, building connections and overcoming their fears about public health meant delayed timelines and extra costs. And it took 18 months to sort of understand how to really have a partnership that made sense and was genuine. Another example I'd share with you was when I was a community organizer and working with a number of different grassroots groups, where the history of those groups in terms of encountering racism and neglect really created a high barrier in terms of building trust, and it took a considerable amount of time of supporting the issues that the group identified as the most important ones to address, which weren't the ones I wanted to address initially, but I had to demonstrate I was willing to understand their concerns and their priorities and support those before it was possible to talk about working as respected partners with each other. So our speakers today are also going to, as I said, offer their experiences. And let me now introduce them. And in order to save time, I'm going to introduce them all at the same time. And so you should try to remember who they are when they speak, but they'll probably remind you. And to make it even more confusing for you, they're not sitting in the order that I'm going to be introducing them. They're sitting in the order that they're going to speak. So, Bob Phillips, I'll start with Bob. You can tell which one he is to my right. He is the Vice President for Research and Policy at the American Board of Family Physicians and a member of the National Academy of Medicine. And today, Bob is going to be discussing his experiences as a practicing family physician who helped to lead the development of a community organization that was responding to a cluster of teen suicides in Fairfax County, Virginia. And he's going to be talking about the work that was done with different sectors, including the work at the high school and the Fairfax County Public Schools, the work with the Public Health Department, and as well as the healthcare sector, to try to put in place a variety of different steps that would decrease the likelihood of either suicide or suicide attempts. The next person who will be speaking is Sandra Lobo, who is the person directly to my right. And Sandra is the executive director of the Northwest Bronx Community and Clergy Coalition in New York City. And that coalition is actually a 42-year-old grassroots community organization with a focus on racial and economic justice. And for over 15 years, Sandra has led an effort to build mutually beneficial partnerships between community members and organizations and various institutional organizations and stakeholders. And that work has been done by the coalition with an intentional focus on anti-racism and social and economic justice. The coalition is focused on the issues that the community actually identifies as the prioritized issues, and those include such things as housing, economic and community development, and access to high-quality, holistic health and social services. And then our final speaker, to my far right, is Maurice Ashe. And Maurice is the CEO and founder of the Oakland-based nonprofit Change Lab Solution. And Change Lab Solution creates pioneering efforts to improve and sustain communities. And among the things it does is it uses tools from a variety of different disciplines, including law, public policy, leadership engagement, to design practical solutions to help communities in addressing a wide variety of issues, but including in those issues is working across sectors to solve problems of concern, and particularly related to health and well-being of the communities. Change Lab actually works in all 50 states, and Ms. Ashe has been actively involved in creating these multidisciplinary partnerships that tackle some social problems, strive to empower community members, and focus on improving health and other concrete outcomes. And by the way, I'd relay that you'll hear this probably also reinforced by Maurice, but there are a lot of tools, briefs, educational materials that are on the website of Change Lab Solution. So as you hear some of the discussions today, we're also going to focus on not only what you can take away from hearing people talk, but where there are materials that you can access to follow up on either comments that the speakers make or related topics. So with that introduction, we're going to go again, Bob, Sandra, and Maurice, and we're going to turn things over to Bob.
I appreciate it. So I'm actually excellent. So I was saying I'm not here in my capacity with the American Board of Family Medicine. I'm here as a community physician, a parent, a basketball coach. My oldest son, graduated last year from Woodson High School, and he and his classmates said to me before his graduation, I've been to more funerals than I have been to weddings. So it all started really in 2012 when one of our scouts committed suicide, and then another scout in the community, not in our troop, committed suicide the next year. And then we had 2 boys commit suicide the following year. all of them athletes. And I happened to be giving the Langmuir lecture at CDC to the Epidemiology Investigation Service, and when I got a text about the fourth one, who happened to be a neighbor's son, and I said, you guys do these epi-aids for communities. Can we get an epi-aid around suicide? Because we have this cluster, a slow burn cluster. It's in one high school. And I think we need to have this evaluated. And I dug back in the literature. I said, you did one of these like 20 years ago. Can we get one of those now? But I went back to my community, and of course, there was a lot of concern among parents and teachers. But there was no cross-communication. So we actually had an event at our school where they opened the school up, and we had over 2,000 parents in the audience. And the public health department spokesperson stood up and said, we're concerned, but the suicide rate in our county is lower than the rest of the state. And I said, that is the most tone-deaf thing I've ever heard. Because the audience went nuts. They were just very upset. I said, the rate in our school is 50 times higher than the county background. So we didn't have engagement, we didn't have agreement about what the problem was. But a group of us of about 80 initially, of parents and students and some teachers and folks from Fairfax County Public Schools came together just to see if we could at least get on the table what the concerns were. It was fascinating, and we made sure that we included students because we wanted their voice heard in this. And what we heard from students is, if I report one of my classmates is thinking about attempting suicide, we're concerned they'll be arrested. So we had to create an FAQ for how students could address their colleagues, their peers with mental health issues. We pulled on a curriculum, First Aid for Mental Health, that was created in Australia. And we got the PTA to fund having 25 students trained in that, just so that there would be people who knew that they were not the answer to someone's problem, but how to triage it and get them to help. And the school liked that so much, they then got all the trainers for the athletic teams trained, because the school was actually not aware that all the students were athletes. And then we got coaches trained. And then we got teachers trained. So we really created a cadre of resources within the school. I'll tell you, that wasn't easy at first, because the school, even the school system kind of circled the wagons at first. There was not trust about what parents would do. There was great fear that there would be blame associated with this. So it actually took us those initial efforts to get First Aid for Mental Health introduced that really started to open up the conversation. There was concern or hiding behind FERPA, the requirement that schools cannot release information about students. And we slowly eroded that. And I did that largely through working through the head of the athletic program for Fairfax County Public Schools to say, look, I'm not saying you have a problem with your sports programs at this high school, but that's where all these people have a common tie. Can we work with you to try and develop some solutions? We found someone who had developed a curriculum of mindfulness for sports performance enhancement at Catholic University for college athletes and Olympians. And we said, can you bring that in? Can we try mindfulness because there's a lot of fear about mindfulness among parents. They think it's associated with Eastern religions and cults. It's really difficult to get people to accept even things like mindfulness. So we brought it in as a sports performance enhancement activity, which sold very well. Sold very well. And we actually did it as a trial. We wanted to know, could we actually assess a difference? And it was fascinating. We actually, with just it actually turned out to be 2 girls' teams. We hadn't had any female suicides, but the boys didn't want to have anything to do with mindfulness. But these 2 girls' sports teams actually were able to demonstrate not only a reduction in anxiety and depression among the athletes, but actually improved their sports performance, and significantly. So much to my surprise, we couldn't get it installed in the school, but it did. Another high school said, we'll take that, thank you very much. But it did introduce mindfulness and an acceptance of it. So some of the parents were teachers of mindfulness and yoga, and so we brought those into the classroom. And not only for the students, but we got the teachers interested so that they would reinforce the mindfulness messages during the day. It was a gradual building of trust at the school system level within the school that allowed us to start to introduce some of these things that we thought might help with awareness and around resources and around support systems. Our Community Services Board runs the programs in the county for how they deal with especially adolescent suicide ideation. And we actually went and testified to our county system and got them an additional $1 million in resources. So that brought CSB right into it. And our students were able to tell them, look, your line for reporting people who are having problems, we really don't use the phone. It would be really helpful if this was text-based. So they introduced the CSB invested the resources to make it text-based, and it tripled the number of reports in the next year. So it was a really good opportunity across the school systems and parents and students. So we started turning to the providers in the community, and the providers were also a little bit scared about this. I don't know what to do with it when it appears in front of me in my clinic. I don't know what to do with it in the county, when it's out there in my community. But we pulled in pediatricians, we pulled in some of the family physicians, and just had them start with, can you create a screening tool for us so that when the 2,500 student athletes go through their annual physical at the school, because they do it as a cattle call, can we introduce some screening questions around mental health and test them to see if they actually function like they should, and to test our system for what do we do when we find positives. And the answer was these students don't want to have anything found that might limit their athletic activities. This is not the place to ask that question. So we decided to instead try and work with our community providers to address it that way. Our health department, it turned out, and I've been very frank and public about it, remained very resistant to participating. The Community Services Board is a function of the health department, and so we had good engagement there. But in pushing for this EpiAid, I actually had to work through the state health department, the state secretary, in fact, backwards to get the county health department to request an EpiAid. Thankfully, CDC worked with SAMHSA to create an EpiAid for our community. It was not implemented the way that we had, as a stakeholder group, had framed it, and I think that happened at the county health department level. Our school actually didn't get visited, which I think is a real problem. And it made the problem compounded because when Palo Alto, a sister community to us, had a similar cluster, the same EpiAid was implemented there. So I'm still working with CDC to try and see if we retrofit the way you do this so that you would do it as if we had 8 cases of syphilis or 8 cases of some other communicable disease, because you don't look around the problem when you do an EpiAid. And that's actually the conversation I've had, because we actually had 3 more suicides over the next year, one of which doesn't get counted because it was someone who was withdrawn from school to be hospitalized for their depression. So there's still a lot of angst, and there's still a culture there, we fear, of acceptance of suicide as a solution. So we continue to work at that. The EpiAid did give us really good data about EHR visits for suicidal ideation, which tripled in the same period. So at least we had some background data to say, look, there is a problem, and we're actually starting to identify a contagion effect in neighboring schools. So you really need to be able to deal with a cluster when it happens to keep it from spreading. We're still trying, we have a stakeholder group with the health department trying to make that a more transparent and inclusive process. What we did with the suicide, so this isn't even the latest article, on May 4th we had another in our school. And we actually went back to the providers and got the Northern Virginia Medical Society offered to help us. We worked with NIMH to identify what is the best screening tool for adolescents. And then we sent that out through the Northern Virginia Medical Society to all pediatricians and family physicians, all physicians actually in general, to say, look, if you're seeing adolescents, this is a much better screening tool. We know adolescents don't always come in to see you, so if you have any process for reaching out to your patients, here is a message that we framed with our school principals. Here's a message to communicate out to your adolescents that might help them seek the kind of health care they need for their problem. And then we also had created a listserv of mental health providers and primary care physicians because there was a real problem in getting people care when they needed it. So we created a listserv so people could specifically say, I have this kind of a patient who needs this kind of service. Can you help us? That would go out to the mental health community, and vice versa. They would say, I have this patient who has these healthcare problems. Is there someone who could take care of them? It's now about 800 providers. And so we also sent that same message out through that to try and reach those folks. It was interesting, the same week I got a notice that lead screening laboratory work in our community was broken. That went out to all providers, but we couldn't get the same public health system to put out a message about this increased risk of suicide in the community. So we're still working on it. It's not all baked, but trust is improving.
Thank you. Thank you, Bob. Now we're going to hear from Sandra.
Well, good afternoon, everyone. Is everyone still awake after their lunch? So again, my name is Sandra Lobo, Executive Director at Northwest Bronx Community and Clergy Coalition. And as John mentioned earlier, we were born in response to what was happening in our community in the 1970s. So we're a member-led grassroots organization. And at the time in the Bronx, there was massive abandonment and disinvestment by both the public and private sectors, incentivizing white flight from our communities and really concentrating poverty in low-income communities of color. And I say that because it really kind of frames the work that we do, who we are, and how we build partnerships. And so one of the first things that we did in the 1970s was, on a national scale, work with partners across the country to prove that racist policy like redlining, practice like redlining was actually taking place, and helped pass the Community Reinvestment Act that forced banks who were taking deposits in communities to actually invest in those communities. And that's important for me to name as part of our history, because when folks look at the Bronx, they often see our deficits. They often see what's wrong. And there is statistics, pretty grave statistics, that could easily allow us to just look at the Bronx and see us in that way. Right? So the Bronx is number 62, ranked 62 out of 62 counties in terms of the worst health outcomes. And the work that I want to share with you today, the Healthy Buildings Program, was created in response to our community members knowing this statistic about us and really wanting to dive deeper in understanding these health disparities that we knew that were there, existed statistically, but also were experiencing on the ground every single day. And really out of a frustration of their own experiences of feeling like what they were being told by their physicians or the Department of Health was very simplistic and in a silo. And so they really wanted to dig in to understand these statistics, but also wanted to influence and impact to get to the root cause of that. So the area, after analyzing our statistics, the area that we focused on, I don't know if the slide, thank you, that it didn't take long for our community members in understanding the landscape of what was happening in our community. It didn't take long to make the connection, we don't think was coincidental, that the communities that had the highest rates, and this is a map of all of New York City, we're at the very top left, the communities that had the highest rates of heat and housing violations, with the housing deficiencies, people unhappy about their housing conditions, were also the very same communities that had the highest rates of asthma hospitalizations and ER visits. And our folks on the ground, our community members knew that although they could eat right and exercise and really take care of the things that they needed to take care of individually around their asthma, which in the Bronx, by the way, has the double the number of deaths that are asthma-related of New York City, 4 times the number of New York State. Folks knew that individually they can do all these individual choices, but coming home to an apartment that had mold or mildew, that did not have heat or hot water, that had roaches or mice, all for those who are engaged in understanding asthma, know that those are really important asthma triggers that in New York City, where most of residents are renters and not homeowners, have very little impact or influence in addressing the housing conditions around them. So this is where the Healthy Buildings Program really arose, right? It was this desire, and we were very savvy at organizing around housing conditions, and yet we had failed to really talk about housing conditions through a health lens. So it was really a training of our community members around the social determinants of health that really pulled this together and really created the idea, what if we looked at the hot spots, those buildings that had the highest rates of emergency room and hospitalizations that were asthma related, and created a table, a diverse stakeholder table of partners that could help us bring financing to help landlords retrofit their buildings, that would bring community members that are trained to talk to their neighbors about their role in addressing these issues, that would bring the Department of Health around and leverage their resources and expertise, as well as our health system, a health provider in our community, and really looking at the data that they provided us to help us channel these efforts. And so the Healthy Buildings program was an opportunity for us to influence this. And I think I'll stop right there.
Thank you. Well, you can stop there, but we're going to engage you more in talking about many of the specifics. So thank you, Sandra. Thank you. And Maris.
Yeah. Hi. There it is. I'm on. It's a moment of personal reflection. My son is 20 years old, and he too has been to more funerals than weddings. 1 suicide and 3 drug and alcohol-related deaths for young men, in high school and 1 in college. So it's I feel the pain, very much so. I'm going to be talking about Change Lab solutions, but mostly about health in all policies. The concept, and maybe we could move to the slide, the concept to integrate health outcomes into all sectors of civic life, and that's the work that we do at Change Lab Solutions. So when you think about transportation agencies, housing agencies, land use planning agencies, schools, economic development, all of them have a major impact on health outcomes, but most of them don't ever think about health. We know, and there was data shown earlier this morning, that a fraction of what we spend on healthcare in this country goes to prevention, between 3% and 4%, and the rest goes to medical care delivery. And one of the major reasons why we're here is to address this dichotomy, because we know 70% or more of what causes poor health has nothing to do with medical care delivery. So the basic idea is that if we will fail, public health will completely fail if we think we're going to use 4% of our national budget to prevent 70% of what causes disease. The way we get around that is by deputizing transportation agencies, housing agencies, land use agencies who have the legal authority, the subject matter know-how, and the financing to transform their expertise into addressing the social conditions that drive disease. And that's what this work is about. John referenced resources. We have literally millions of dollars worth of resources on our website, free for download for you to use, model laws and policies, toolkits designed specifically for health agencies and community-based organizations, and now increasingly hospital systems that want to get into addressing these core fundamental social determinants of health through public policy. So I want to give a couple of stories of how this works and why it's so important. I want to talk about food access, physical activity access, housing, and tobacco control. Food access. We worked with the city of Fresno, California. If you know Fresno, I'm based in Oakland. It's in our Central Valley. It's the fruit, vegetable, and nut basket, really, of the country and one of the major in the world. In the city of Fresno, which at the time, and still is, one of the poorest cities in the United States, a lot of farm workers live there, a lot of immigrant families. In the lowest income neighborhood in Fresno, you are not allowed to sell produce. So there was a food desert. In the land use planning code, it was very old, 40 years old, nobody knew how it got there, but in the code that regulated how you could use land, you were allowed to sell alcohol. It says it explicitly: alcohol, tobacco, confectionaries. You could have a deli. Produce may not be sold. So not surprising that people did not have access to healthy foods, fruits and vegetables in their neighborhood. In Fresno, you could not have a farmer's market. There was no definition of a farmer's market in their zoning code, and if there was no definition, it couldn't exist. So by taking a very critical, health-forward look at the zoning code, there were great problems. Now, to the city's credit, of course, they changed that. Nobody had noticed it before. And that all got changed, and Fresno's using their farmers market as an anchor for economic development in their central city, which had been kind of gutted out over the years. So that's a really clear example of how law and policy link directly to health outcomes and the social determinants of health. Another example is the lack of access for what I would call play justice. In so many communities where there's no safe place for kids to play, for older adults to walk and be in their community, for many people to be able to enjoy their community and get active transportation and necessary physical activity. So I want to use an example in a rural community, both in California and North Carolina, where there were no playgrounds. There are communities, and California is not unique, all throughout, I know, the Southwest and into Texas. They're called colonias. They're communities that, where farm workers have lived because the fields are nearby. They have no social services they're unincorporated, so there's no sewage, there's no garbage collection. They have only well water, no municipal water, no housing code inspections, housing codes, let alone inspections. These are very common throughout agricultural regions throughout our country. There was a school system in this small community that, like many, particularly in low-income communities, was gated and locked up at 3 o'clock when school was over, closed, and that was the only place that there was a soccer field, the only place where there was a gymnasium where after-school activities could happen. This is common across the United States. So the school district and the public health district worked together to open up that playground for after-school use. And now it's not just for kids, but it's for parents, places to go and play and recreate. This same work through Community Transformation Grants, CDC funding, was going on in North Carolina. And the state school board said, forget about it, it's not gonna happen. What did happen is the faith-based community stepped in. And in fact, in rural North Carolina, there are a lot more churches than there are schools. And that faith community said, our purpose in life is to invite in the visitor, that our hospitality and the unknown person is always welcome in our community. And so their message of faith and their religious beliefs blended with the public health needs of the communities they were serving, and bringing in the unknown kid who can now be part of our community to open up our big church hall for jazzercise or exercise or other sorts of community needs. These kinds of activities, we started getting word, were leading to, particularly in urban settings, to gentrification. You improve the park, you put in bike lanes, you get access to healthy food, and that was pushing us out and bringing in white people. We don't want any of that. Things are just fine. Thank you very much. So our work has had to really move into that area and start talking about how do we do this work while protecting, enhancing affordable housing. How is it that we don't displace people at the same time that we're bringing absolutely essential amenities into communities that have been under-resourced for decades? I'll stop there because I'm getting the sign there's more to say about all of this through a Q&A.
That's great. No, so, well, let's applaud Maurice. And so, again, you have to imagine that we're your dinner guests. And so everybody had a chance to say something, and so now it's your opportunity to chime in as well. So this is unusual in this kind of setting in that we've really scheduled a lot of time for questions and comments, and so take a minute or two to think about either asking a question or sharing your own experience. I'd say what we're trying to do ideally in this kind of conversation is to think about what are the lessons that are transferable to other situations that you're involved in. Because we can talk really specifically about the individual experiences that we've had. They're, as you've heard, really interesting to talk about. But the greater value would be saying, what can we take away from that would allow us to do work better or differently in our own community or setting? So I'd encourage you to maybe think about that in terms of your questions or what you would share. So get ready, and somebody's going to walk around with a microphone in a minute. While people are thinking about their questions, though, I want to ask the three of you to maybe spend a minute each thinking about a particular challenge or obstacle that you faced in terms of some of the intersector work, where it might have been the kind of thing that would have just stopped the work there, or you could have just said, this isn't going to succeed. But there was a thoughtful way or a creative way to think about how do we overcome that obstacle? How do we think differently so that we can not lose the work on this important issue? So I would open it up to whoever would like to share that experience.
So I neglected, could you put up the slide for the Community of Solutions website? I just want people to be able to find it if they want to. So this is our organization and the resources that we've developed, and it can give you more information if you're interested. So one of our particular difficulties was, of the 8 students who committed suicide, 3 of them were Scouts, 2 of them Eagle Scouts. And while we were able to bring in counseling services into our own particular troop for the Scouts who knew the other Scouts, we couldn't get our local scouting group to actually think about scouting as a platform for teaching leaders how to look for signs of problems. But we didn't give up on it, so one of my fellow Scout leaders who was going through Wood Badge, if any of you are in scouting, it's kind of the leadership college of scouting, I said, could you talk to the Wood Badge Leadership Platform Development team about potentially developing a first aid for mental health as a component of this? So he actually made it his Wood Badge project and wound up getting the right people in leadership. So now National Capital Area Council, our major council in Maryland and DC and Virginia, offers first aid for mental health training for Scout leaders. And we're trying now to reach out to the folks in Palo Alto about starting on the West Coast to try and get that introduced as well. So it was a matter of finding the right venue and finding the right people to reach to make that happen.
So just following that up, if you couldn't find the right person, how did you find the right person?
We found the right track by working through the leadership development training process. It made sense as a training opportunity since we had a curriculum that already existed. And reaching the right leadership in that training venue who understood this is a training opportunity. This is not scary. This is not trying to go and talk to troops about suicide or suicide prevention. It's how can we actually train leaders through our normal training process to recognize and triage mental health in their Scouts.
Thanks, Bob. Sandra?
Go ahead.
Oh, we had no challenges. It was a piece of cake. I only have 1 minute, right? So what I failed to say earlier, just in terms of time, is so the goals really weren't just about reducing asthma. It was also about affordability, right? If we're doing retrofits, how do we ensure that these tenants are not going to be pushed out? It was also looking at energy efficiency and using that as an incentive. And it was also thinking about the ways in which we could develop leadership in our tenants. So after we walked away from a project, that the leadership of that building can continue to do that work, while also ensuring that the work that's happening in the building is actually hiring local folks, right? So it's not, that wealth generation is not going somewhere else, it's actually being captured here in the community. So you can imagine bringing folks from across the sectors, right, coming together and heading in one direction. There's a lot of challenges there. I think what's relevant to me as a community, bringing the community voice here, though, is what I will say is we had been thinking about this kind of project for many years, and no one really took us seriously. And it was because of the funding from the Build Health Challenge where it was a grant that required that the community be the lead partner with a health system and a Department of Health that allowed us to be taken seriously by the Department of Health and our health system, as well as other partners. And that was huge, right? Because there's a big power dynamic between a community organization be taking seriously about the types of ideas or solutions that they have, and then how to come to a table and have an equal say. By no means was, a power dynamic still exists, and by no means was it easy, but that was helpful in having a seat at the table and guiding a process that's collaborative, that has community have a say in the same way as health professionals, as government. And for us, also really important in that piece there is, for us, it was not just as important, it wasn't only important to reduce the asthma triggers, but to have the community kind of name for themselves what they need and be part of the solutions that were gonna take place, right? We had an idea that came from some community members, and then once you dissect it, maybe it will change, but community had to be there all along. They had to be there to understand what were the challenges and to kind of solve those problems.
I'm going to build on that a bit and talk about the other end of the policy win, because what happens a lot, and it goes to the leadership development, and I've just been doing this work for a long time. We won the policy, and then move on to the next challenge. And nobody watchdogs that policy. Is it being implemented? Has there been one dime of public dollars put to solving the problem? Or is there just a piece of paper that everybody pats themselves on the back? We care for kids so much in our community. And then move on quickly. Nobody's assigned, nobody has accountability to make sure this is working. Nobody's measuring if it's working, because maybe there's unintended consequences, like in access to healthy food and physical activity leading to gentrification and displacement that we need to know about and deal with. And nothing happens. And it's the leadership at the community level, people knowing that they have rights to a safe home, a healthy home. And through all of that policy development effort, engaging the community to maintain that watchdog capacity after the policy win, to make sure that it's actually implemented in the real world, having the outcomes intended, dealing with unintended consequences if they're there, and ensuring that those families really are getting what they deserve and what they put all that energy into. So it's just an extension of the policy win into the implementation and enforcement phase. Absolutely critical.
Okay, I'm going to just, before we open up, what I heard was among the things that overcame the challenges were perseverance and creativity, and how to message it and how to continue to find somebody. If one person says no, find another person. Having some resources which give you a certain degree of leverage in terms of getting people to the table, and maybe being taken more seriously than had been the case helps, and that the view of looking at this as a process and not a single event or achievement, but something where there has to be continual focus. So I'm trying to tease out some of the lessons. So questions or comments? And who has the microphone? I'm just trying to see. Raise your hand if you have the mic. Okay, there's the microphone back there. Okay, so I will rely on you to find people in the room, but there's some on both sides. There's a mic on there. Oh yes, okay, fine. So why don't we take one from one side of the room, one from the other. So please stand up when you have the mic.
Hi.
Can you tell us who you are?
Sure. Kelly Teeter, Denver Public Health. So I suspect, and I'd like you all to comment on this, that part of our issue here is that we under-resource and understaff some of these activities. So it sounds like some of your work is done volunteer and some of it is paid staff. Could you speak a little bit to the nuts and bolts of that? Like it took 3 full-time volunteers or 22 part-time volunteers to do the suicide work, or it takes 5 staff members in the Build Health Challenge, or whatever, because I think we get all these ideas and we go back and we say to somebody, could you take 0.2 of your FTE and just do this thing they did in the Bronx and let me know how it went?
I'm glad to start in with that, and I don't have a specific answer because every situation is going to be different. But I think the idea of health and all policies is leveraging other people's money, resources, and talent expertise. And so health departments cannot successfully address the social determinants of health. They will never have the resources. They don't now, and I don't think it's going to get better, I'm sorry to say. But a city can, if there is sufficient political will, which takes the community organizing to create that political will. And if there are relationships from the health department to transportation and housing and land use and you just go in all the civic services. There is the capacity to answer these questions, but it takes leveraging other people's money, expertise, staffing, and resources. So that's a very global statement, but health departments cannot do it by themselves.
You want me to go next? It's a hard question. I think what was really essential for us is, so we were already leveraging so much of our funding doing a variety of work, our health work, our energy work, housing work, and I think what was unique here, I don't have like a specific number that's applicable for everyone, but I think for us was that the Build Health Challenge allowed us to cover, I feel like no funder ever wants to hear, and I hope there are funders in the room and can talk about this, no funder wants to hear that their funding has paid for relationship building. They're not interested. They usually is like, how many people did you help? How many houses did you retrofit? How many, and the Build Health Challenge gave us the flexibility. It took 2 years to build a table, to build trust, to build relationships, to build partnerships. And we're still, it's still a journey. And that allowed us to do that. And that actually did take like 2 to 3 staff people to do that, because the sectors are so different and they're used to doing work in a particular way, and to shift not only their way of thinking, but to trust that doing something different from what they're used to is going to have a payback, takes time and intentional relationship building. So for us, it was not just the staff to do the deliverables, but it was the staff to build that table and to build those relationships.
Well, and as an activity born out of crisis, ours is entirely volunteer. So we have more than 300 people who regularly talk on our Facebook page. There's probably 12 of us that work consistently at this. And so it had to be very organic. It's, what are the things we would like to see happen? How do we boil those down into who do we need to target? And who has skills or expertise or relationships to lean on? I couldn't build a website, but one of our parents could. I mean, it really is that kind of organic. So sustaining it, again, because it's a crisis-focused activity, but has a long-term, you really want to try and reduce this problem long-term, means that we had to try and figure out how do we systematize some of the changes? How do we make this a function of the health department? How do we make this a function of the CSB? How do we make this a function of the school system? But lastly, how do we maintain that communication stream back to parents who can continue to develop and maintain the trust to be part of the conversation, so that when the crisis happens again, we have a way to respond. That's been our difficulty, and it remains very organic.
Maybe I would just weigh in one other thing too. As someone who is a local health and a state health official, my experience with that was it was really hard to find the resources to work in other sectors, because we got categorical funding that paid for disease-specific work. And so that you didn't have flexibility in terms of where you could assign people. I headed up a really big state health department, and we basically could do very good work in one other sector, we decided transportation was the sector we were going to work on. We freed up a person who for 18 months, that was her job, to work with that sector. That was a really big sacrifice. We wanted to work with like a dozen different sectors, but we just didn't have the resources. So I think it's good to be, I'm thinking of Bob's experience, good for a health department to be nimble enough that they can be supportive, even if when a crisis occurs or a need arises, even if they can't put lots of resources into that, there are things they can do to be supportive, and that's important. But I actually think we should be realistic about how hard-pressed health departments often are in terms of having the flexibility to have specialization to work in all these different sectors, which is not, like a few phone calls. It's like showing up at meetings month in, month out, building the partnerships Sandra was talking about. I think it's setting your priorities and picking where you're going to make the concentrated effort to have a success, rather than thinking you can do it all with superficial, kinds of relationships. That also is part of the mix. I wasn't sure who's next. Is someone on that side next? And then saying we're going back and forth, maybe just. And I feel bad for you all because I think you're not able to. Can you see people beyond the podium?
I can see you on the screen.
Okay, fine. Okay, sorry.
So this is
because we can't see you. So.
This is a question for Sandra and her work with addressing the asthma and housing in the Bronx. And I'm just curious, in your efforts to try to build collaboration, were there any innovative success stories that you can share working either with the landlords, who seem to play a very important role, or perhaps with the faith communities, something that may not have been the normal way of trying to address this, that could be an inspiration for others around the country to maybe try some similar things?
Absolutely. It's like I secretly asked you to ask that question. So our tradition of working around housing issues in particular is a grassroots, a very traditional organizing. You have a target, you know who your allies are, you try to engage them, and if they don't respond, then you escalate the interaction and try to get what you want. And with landlords, tenants, make complaints, they call 311 in New York, you can, put violations. But nothing often happens, right? So they create tenant associations, and oftentimes we end up suing the landlord that's just non-responsive, right? If you're in the middle of winter in New York City and there's no heat and hot water, and you have rats in your apartment, and you have a newborn, and you're afraid of putting your baby in the crib because they'll be bitten in the middle of the night, and the landlord is unresponsive, we help tenant associations sue their landlords and give them some basic rights in their housing. That is the traditional way of getting what we want. And we knew that in order to be really holistic about the type of work that we wanted to do, that traditional approach, while still necessary, and we still do that now, there was a real concrete need for landlords to have access to financing, to do some of the retrofits that they wanted to do, in theory, but didn't have access to, and that there were other folks that could bring in resources that we did need the partnership of the landlord to be at the table, right? So for this, it was partnering with the finance sector to provide low interest or just grants to do the retrofits in the buildings, and having them at the table with the tenants and talking about what needs to be done, and trying to pull together the resources, kind of problem solving together. So instead of suing the landlord and forcing him to do something which then he does at surface level, painting over the mold, and 3 months later it's back there again, it was really kind of digging in with landlords and tenants and lawyers and finance people and the Department of Health and all these folks to say, what are the resources that we can give you to retrofit the building? And now you're going to sign this agreement that agrees to make sure that the apartment is affordable, that you're not going to bump these people out, and we're going to train these tenants to talk about integrative pest management in the building, and they're going to be trained on how to do community surveys. So there was this really comprehensive approach that was very different, and actually in many ways was very scary to us, right? Because just like every other sector is used to doing the things that we're used to doing, for us to partner with landlords was like, oh, no. You can't do that. And it was incredibly innovative, very, very hard, but really powerful in having people think about it. It's not about fighting, right? It's about building, and what can we build together? And at this, where we are in our political landscape, we need to fight, we need to protect our people, but if we keep fighting, then we'll still be fighting 20, 40, 60 years from now. We actually need to be building too. So the work that we're doing builds that leadership in our tenants, but also is looking at the long term. How do we ensure that's affordable long term?
Great answer. Thank you, Sandra. Yes. Oh, sorry.
Okay. Oscar Allen from Show. I'm going to try and at least hopefully a couple things. You had mentioned being number 62 from the Bronx and the community health rankings, and you also share that bottom rung with Sullivan County, which is not far from you, 61. and they're totally a rural health department, a rural county that has the same issues. What I need to ask is, when you talk about the access, the interests, the capacity, and the generation of resources together from that movement, as you just said, from fight in to build in, and the current landscape that we see ahead of us with respect to support for these type of endeavors, plus your geographically minded concerns. As you know, there's this whole area called Sobro now, which no one called it that. It was all South Bronx, but people are being displaced because it's cheaper and they can make more money. How are you able to sustain that effort to see true change, changing, at least moving you up the dial from 62 to maybe 61 or 60 or 55 or number 1? How realistic are you in the encouragement that this collaborative approach will find some indicators of success?
That's an easy question. For us, I mean, we have an evaluation process in place to help, and it's a very small pilot. If we prove success in this pilot, can we then get to scale? And that, if there are any funders in the room who want to invest, we want to try to get to scale. I mean, for us, it's about scalability. If we can prove success, we think that the real dial change that you're talking about is large scale investment in moving these like innovative pilots that we see popping up all over our own city as well as all over the country, is that we are invested in to do those initial projects, but then how do we get to scale? And then it's comprehensive, I would say, is the second piece. Is we're not just looking at the asthma triggers, we're actually looking at the economic base of folks in our community, right? That we know that your health outcomes are connected to how much money you make and what the housing conditions are. So it's like looking at it multifaceted approach to seeing how do we shift not just the asthma trigger health outcomes, but also the other health outcomes that are connected to the social determinants of health.
So I want to build on that and say that the spread and scale can come through public policy. So there's a public policy called prospective rental inspection programs, where landlords pay into a kitty that funds both routine inspections of housing, so tenants don't have to complain and put themselves at risk for retaliatory eviction, and sets up a low-interest loan program for those landlords to access to make the improvements. That's what gives the carrot for the landlords to not oppose this totally across the board. Once that's in place and working well, it should be a virtuous cycle on a public policy, from a public policy point of view. Not that you don't need to watchdog and tweak and make sure it's working well, but that it should be self-reinforcing and improving the housing stock over time. I love the idea that I just heard literally on this panel, and we will amend our model policy over time to tie access to those dollars to an agreement from the landlord that the rents will remain reasonable because the interest rates are reasonable, and it shouldn't be used as a way of improving property to simply displace the low-income tenants. That's brilliant, and but this is the policy. Well, then you can move on to another issue. Once you start improving the housing stock, you can move on to the economic development opportunity, et cetera, et cetera. So it's the policy. So we're not just doing program after program and the leadership changes or people move away and you start over again and over again. You got to get things locked in so that you can make continuous improvement.
Great points.
Prospective rental inspection program, PRI, is,
We'll do a final question at the end. I'm letting you know now, where I'll ask each person to remind the folks who are here how to get resources to follow up on the topics we're discussing. Is there a question on that side of the room? Okay. And then it looks like there's folks, microphone folks, there's folks in the middle too, I'm hearing, are interested. Yes?
So this is a bit of a comment and a pivot to a question. The comment has to do with sort of my own personal experience of having the unfortunate fact of diagnosing my son with leukemia. And this happened when he was 4.5, almost 5. And he just got accepted from a preschool into a fairly competitive school This was in the Berkeley environment. So he'd gotten accepted, you know, tested him and all that sort of stuff. And then the diagnosis came down, and so he went through pretty heavy induction chemotherapy. And the point was that he actually arrived at the school for the first part of that fall bald, right? He'd lost all his hair. And from my point of view, that was a great outcome because the leukemia was in remission. From a social interaction, we caught nothing but disastrous relationships with these parents who actually were trying to ban my child from actually going to school because they did not want to have their children have to deal with the question of death or concern of illness, of severity, et cetera. So that triggered, with me, you're not going to get away with that too much. So that triggered a whole lot of very intense discussions with the parents. There's a movie called, it's a Charlie Brown movie that talks about this little girl that loses her hair. So we really kind of pushed for showing this movie to the parents and the children, because it was really some of the older kids that were showing kind of meanness to this little first grader coming in. So the outcome of all of this for me is a question of empathy. So there was no empathy from the parents about this child. It happened to be my child, but I saw it in how they dealt. It's kind of like your discussion around the crisis of dealing with the suicide. So I wanted to ask the question about your thoughts about empathy and trying to figure out the experience that you guys are all as cross-sectional looking about each of your examples. So it's lack of empathy for the other children that died from suicide in your school, lack of empathy from the system, so to speak, the public health kind of thinking that was only infectious disease or categorical funding angle only, or lack of empathy about the asthma and the children in that community, or lack of food in others. So the question becomes, could you talk a little bit about empathy in terms of us being able to be in action about that at the local family, community, school, and the broader national and maybe even global? Because I think that's what we're missing. I just don't know how to actually put it in action to solve some of these issues, because it's going to keep happening to get to resilience. Thanks.
Thanks, Ahmed. I think empathy is a really important, I think it's a really important idea here. I think empathy requires you to be pretty high on Maslow's hierarchy, right? And if you're afraid, you can't get to empathy. At least it's very difficult to get to empathy when you're afraid. And I think there was so much fear in the health department and in the school system about this happening in our community and not knowing how to deal with it, but not wanting to be blamed, not wanting to be shamed, not wanting to be engaged by people who, with even good intent, might just increase work that wasn't helpful. All those things kind of came into play. I don't think they lacked empathy as much as they couldn't get to it. Once you got the trust level up, the empathy came. There was still a lot of trust issues because they didn't want to be exposed publicly, and so a lot of the conversations had to be in a very trusted place. The next kind of phase of empathy was on our part, because we had to understand, we had to be empathetic about why are they behaving this way? What are the things they might be thinking about that would have them be resistant? And then how can we address those? So I think empathy cut both ways, and it was a solution in many ways once you could get to it.
I think we have time for one more question, and then we'll do the resource reflection on the part of the panel. So one more question? I can't see, but yes, okay.
I just wanted to ask, I guess, and it applies to anyone of you up there, when you're thinking about these collaborations and establishing this trust with these groups, what has your experience been with, you get them at the table, you think you have at the table who you need, how do you keep them engaged, and what are the challenges that you have faced, and how have you overcome those?
I think it's a really great question, because there's all these collective impact this work is going on all over the country. It takes, as Sandra said, a long time to make some of these changes. And some of the changes we're working towards are generational. I mean, really long-term, that absolutely essential that we've got a vision for the future. So celebrating small wins is really important. The celebration of even little successes, the training of leadership, even if people don't stay at the table because they move on to something else in their lives, they have something that can't be taken away from them at the community level. Again, relying on public policy as a best friend, so you know that you've got a basis, a foundation that you can build from and work beyond, and not just the same battle over and over again, because that's really, people give up and get cynical and exhausted. So I think there's a lot of different strategies, and I think it's hard. It's care and feeding of your people. It's the open dialogue. It's setting good agendas that people want to come and participate in.
Yeah, that was great. I mean, I would echo everything that you said. I think for us, from the very beginning, while we had an idea of a project, that the folks that were coming around the table were authentically contributing to the design and the implementation. So they weren't just coming and giving us feedback and then we would go and make decisions some other time. It was collective, authentic collective decision making, which is scary and time consuming, but allowed folks to stay at the table because they knew that they were actually building this thing together with us. And the other thing I would say is alignment and mission, and that in the very beginning, the relationship building piece wasn't just the individual relationship building, but also how does this benefit you? It's not just because we want it to benefit us, it's how does this help you achieve your mission, or how does this help you connect? An example is we had Aero NYC, which is like the home-based asthma management care, and it's a implementation that's really great, and the challenge is they have this really great program that would come into the person's home and do all this stuff, but no one was answering their phones or opening the door because there's no trust for them to come into communities. But being connected to us as a community-based organization, saying these folks are legit, this is, you could be undocumented and no one's gonna, you're not gonna get in trouble for it. Like, this is an authentic, legitimate resource for you. All of a sudden, there was more access to the community, right? So it helped their mission and what their goals were, and thinking critically about who's at the table and how does this project actually help the other organization and not just for one vision.
The only thing I would add to that is, because I completely agree with it, and the group of us, a lot of us were sociologists, we were psychologists, clinician. Where we didn't do well is in playing hardball, which is where we are now. It's how do I drag you to the table and make you understand that you need to be part of this. None of us are very good at that. And so now we're trying to recruit people into that space who we can trust to be that drag you to the table, but still follow through on what is our mission, not get distracted by whatever they're angry about. So the hardball piece can be hard, but sometimes you have to do it.
Thank you for the questions, everyone. I wish we had more time, but we're at the end of the time period. We do want to close with getting more resources, how people can follow up. I would remind folks that with the support of the de Beaumont Foundation, Duke University has developed wonderful resources and tools through the Practical Playbook website. So you can always go back there, of course, for resources. But maybe I'd ask each of you for people who are maybe interested in your particular work or the materials that have been most useful for you, how do they access those? And Sandra, want to start?
Sure. Well, our website is www.northwestbronx.org, but my contact information is also in the booklet, and a lot of the resources that have been really helpful to us is actually has brought a bunch of technical assistance providers and just folks that are doing similar work across the country kind of sharing, and so that's also available on the website.
Thank you.
The Community of Solutions website is up and open. I said that we have a Facebook page. If you search on Community Solutions Fairfax, you'll find it. I would also point you to SAMHSA, which has, as I said, with CDC, developed this EpiAid. I think it could be implemented differently, but the fact that it's there is good. And the last thing I'd say is to look at Palo Alto. Their community has been very transparent and out in front on building these collaborations, and I think they have a lot of good resources up, including a movie about their whole experience. So, thank you.
Our website is www.changelabsolutions.org. I have just a small handful. It's called Tools for Change. It's like a menu of our top downloaded resources here if you want to pick one up. Better to get it online because it's hyperlinked online, but if you want to scroll through it. And just to say thank you to the Centers for Disease Control, the Robert Wood Johnson Foundation, Kresge, MacArthur, Kellogg, all philanthropy, and many of you in this room. We have learned with and through to improve these products. So they're there for you to use, please, and make it active. And you're welcome to, I'm sure my contact information's in there too. Give me a jingle, pick up a card, get in touch.
Thank you. You know, I think the bottom line, I think that that's been illustrated by the panel is, you know, it's important to and also possible to do the cross-boundary work. And it's complicated and messy and requires having a range of tools and approaches and being creative, but it's doable. We have success stories that we can build on. And so please join me in thanking the folks here who've shared their success stories.